Okay, good evening, everyone. Thank you for joining us for yet another webinar in our Pediatrics series. Once again, it is my absolute pleasure to introduce Dr. Helen Armstrong, who is a consultant in neurodisability. This evening, she will be telling us all about different careers in pediatrics, and also we'll be touching a little bit on specialty applications. So I will hand it over to you, Dr. Armstrong.
Thank you very much. So, careers in pediatrics. So a little bit about me. Those of you who've seen other presentations I've done will probably already know that I've been a consultant for about 4 years now. I work in Calderdale, which is Halifax, and the Huddersfield Trust. I'm a generic instructor course instructor, and I also teach on APLS and NLS. I'm part of the instructor team for the STEP, which is part of the Yorkshire and Paediatric school teaching programme. I volunteer with the Ellen MacArthur Trust. I used to be a trustee on a children's holiday. Purveyor of fine reptiles. I actually just own some fine reptiles. My dream reptile is a little chameleon like this guy down in the corner. Tough mother enthusiast is probably a little bit more excited than I am about it. I do love doing it, but it is also shocking. I love gigs, and I also surf and skateboard in my spare time. Just a word from our sponsors. CPD Me. I might let James do this. I can see him just popping up.
No, absolutely. So yeah, CPD Me is currently our sponsor, which allows us to upgrade the website that we have, mindthebleep.com. Which makes it run more smoothly, gives us more service space. But what they provide for you guys is a 50% discount, so only £8 for an entire year, and access to all their different CPD accredited webinars. So quite similar to these, but on an entire variety of different subjects, and really good for all you foundation doctors who need to build up a portfolio of non-core teaching and learning. And for an entire year, just £8, you can view these thousands and thousands of free webinars. And that is it. And I'll hand back to you. And oh, actually, before I hand back to you, I will just say, if anyone does have any questions as we go through, I will be monitoring the chat on the side of the screen. So do just stick it in there and I will relay it across to Dr. Armstrong. Okay.
Fab, thank you. So, I have to say, this probably looks like a completely random slide, but I loved the Christmassy theme so much, I just couldn't help myself. So unlike your traditional medical school lecture, I've not done a aims and objectives. Essentially, I'm going to talk to you a little bit about how to get into pediatrics. I'm going to talk to you a little bit about what to do when you're there. I'm going to tell you a little bit about the day in life as a consultant. A little bit about the doors it can open for you, the subspecialties you can think about. I'll even, if you'd like, talk a little bit about the process of applying for specialties, and of course, answer any questions you have. I'll do my best to answer literally any, but if they are pediatric based, that's probably easier. So, how to get into pediatrics? It had a time scale of a day. I didn't change that because I thought it was funny. So I think you need to wake up with some enthusiasm. I think enjoying a challenge, because let's be honest, if you don't think PEDS is going to be a challenge, you're probably not aware of what PEDS is. I think that's probably true of most of the medical specialties, but PEDS is. Ask yourself, why is pediatrics for you? Because if you don't know the answer to that question, then when someone asks you that at interview, you're going to be struggling. Then always make time for lunch. I am the kind of person that gets hangry, and so lunch is very important, and it's better for your brain and your patients. Consider things like EPLS, which is the European Pediatric Life Support, or APLS early. Now, that doesn't necessarily mean in your F1 and F2, unless you're super duper keen. I know people that, in fact, I did EPLS when I was F2. Saying super duper keen, I did it. You don't have to do them as a necessity, but they're quite fun. And if you're really, really thinking about PEDS, it's something nice to say that you've done. you could even consider doing part 1 of your MRC PCH, which is the foundations of pediatric practice. I remember when I was in F1, my best friend was doing MRCP, and he'd done part 1 and part 2 before the end of F1. And I was like, what are you doing? But actually, it's not such a terrible thing to start. Now, I probably wouldn't do it in F1. I'd probably have a look into it and maybe think about doing it in F2. But it used to be called 1A. They now have clever, weird, shortened names like AKT and things that I don't totally understand. Essentially, what used to be 1A, which is essentially like the background of pediatrics. It's where all your physiology and all that kind of stuff that you're probably super good at because you've not long been out of med school. So think about it. And then also have an idea what you're aiming for. And I don't mean you need to know where in pediatrics you're going to end up, because I don't think I did when I went into pediatrics. And I don't think I did when I was an ST3, or what I thought changed over that time. But they will ask you that kind of thing at interview. And so it's good to have an answer, even if it's, it's not set in stone. We're not saying, oh, once you say that, you can never be anything else. But it is a really good idea to have those things ready. Then, things not to forget. And by this, I mean things to include in your application, or things to be thinking, I've got an extra hour or 2 of my time in my life. I'm sure many of you don't, but if you have, think about all those fun things or life enriching things that you do that could also show that you're A, a good human, and B, that you might have commitment to your specialty. Now, think of all those wonderful colleagues you have that have wanted to be surgeons since they were about 2 and have, been doing like surgical skills and placements with profs and things like that. Now, we don't expect that in peds because, well, we like dedication on a softer level. And not soft in terms of we don't want you dedicated, but just you don't need to be hardcore as a human. But if, for instance, you have done some kind of work with, say, your local church with a children's group, or you run mums and toddlers, or if you're really good at BLS, you've during, well, you guys won't be old enough perhaps to have been out there when there was the junior doctors strike, but I was. And I essentially spent an afternoon in a church hall teaching resus to kids' resus to parents. It was amazing. But all those little things that you might not think, oh, that's a really good thing to talk about at an interview. But think about all those things that make you stand out from your peers. Because those are the things they're looking for. They're looking for you as a rounded human. And also that you clearly have some interest in the specialty you want to go into. We don't necessarily expect you to know everything about pediatrics. I'm pretty sure I didn't when I was an F1 and F2. But I, as in my to-dos, gave a pediatric job a go. Because sadly, where I was, I couldn't find a job that had the 3 things I thought about, because I thought about GP, A&E and peds. I couldn't get those 3 together. So I ended up doing GP, A&E and peds surgery, which was close enough because, to be honest, by the end of my F1, even though I was doing gen med and gen surgery, I was in a DGH. And when I did gen surgery, none of the other F1s wanted to go to the peds ward when there was like a potential appendicitis. And I was like, oh yeah, I'll go down there. So you may find yourself as someone that's watching these webinars thinking about pediatrics, that you kind of just fall into those things anyway. But they're just great things to talk about when you come to interview. Then, of course, because I have to think as someone that reads applications, think about doing a pediatric related audit or QI project. And that's more doable than you think, even within F1 and F2, or even as a med student. It's essentially tailoring what you've got to where you want to be. So I remember when I was in F1, like I said, I did general surgery, hated it. But what I did do was an audit of the appendix cases in children. And then when I went to GP, I also did an audit of how many pediatric patients we had come through and what conditions they had. So much like audit is more fun if you have any enjoyment in it, I would also say if you're looking at a particular career, and that's not just for pediatrics, that's for whatever area of medicine you finally want to go into, try your best to tailor those things that you have to do for your portfolio or for progression towards what you think you'd like to do, because it A, shows that you're interested, and B, it actually gives you a bit of a flavour for what the rest of your life might be. Because I'm sad to say, guys, that QI and audit doesn't go away. We all wish it did. It just becomes, something you accept. And then volunteer. You don't have to volunteer, number one. I know lots of absolutely wonderful pediatricians who don't do any volunteering, and that's cool because you've got other things in your life, and that's all right. But what I would say is, it is the thing that probably made me want to do pediatrics the most without me totally realizing it. So I started doing the St. Giles holiday when I was a fresher at university. And I loved the holiday so much that I then went on to volunteer with Action at Leeds University. I then went on to lead the holiday after I graduated and then become a trustee. And then I ended up doing neurodisability because we took away kids that had additional needs. And I'm sure there was some kind of subliminal messaging that happened all over that time that led me to now. Because you naturally kind of gravitate towards the things you enjoy and the kind of people or patients that you relate to and enjoy spending time with or enjoy helping the most. So the crux, and you will see that this theme comes up a lot in this presentation, think about what you enjoy and what you are good at, because that is where you will thrive and where you will have the most satisfaction and enjoyment of your work and life in general. What's expected of you? Now, I'm sure my colleagues would probably say very similar things, but these are the things that I expect of you. And this is once you become a paediatric trainee. Though I would love my F1s and F2s to be equally dedicated, though perhaps not get your MRC PCH done. So I would love you to have enthusiasm. And that doesn't mean you need to be like a shining ray of sun every day, because A, we all have bad days, and B, it is work. We do understand that. And, when there's 20, 25 patients waiting on an assessment unit, we can't always be a ray of sunshine. However, that doesn't mean you're not enthusiastic. And enthusiasm, I more see as when you're in a teaching session, you appear to listen and that you have questions, and when there's interaction, that you make some effort to interact, and that when you're interacting with children on ward rounds or in clinic, that you seem to care about that interaction, as opposed to it being something you're scared of, which I do see from art. So we have lovely fourth year medical students from Leeds and third year medical students from Sheffield that come through Calderdale, and it's really lovely actually seeing the transition from week number 1 to week number 6 or 8, which it usually comes in 2 forms. It's either they thought they'd like pediatrics and now they love it, or they are terrified and they're not quite so terrified anymore. Because there are people who are scared to pick up babies, and babies are actually more robust than many older children. So enthusiasm is good. Dedication, because let's be honest, you haven't got this far by not being dedicated, or at least most of you haven't. And I'm afraid that doesn't stop, because pediatrics, at least in its traditional form, is an 8-year specialty from starting ST to the end. Now, to be honest, RCPCH Progress, which is the new curriculum, is shortening that and encouraging flex. So essentially, more than ever, you have the ability to make your pediatric training what you want it to be. So if you want to go 80% or 60%, you don't need a special excuse for that anymore. And by a special excuse, I largely mean having an illness or having children. You can now just be someone that thinks, I'd quite like to have more of a life in my life. And so an 80%, one of my friends has just gone 80%. It's the best thing she ever did, she tells me. I, as a consultant, work 3.5 days a week instead of 5. Love it. Highly recommend it. And so there isn't so much this set path that you have to do. There's some key milestones, a little bit like children. But there's lots of ways of getting to the same end point now, which is brilliant. You know, more than ever, they're encouraging that if you think to yourself, would I like to be a GP with a special interest in pediatrics? Well, then there's ways of going both ways for a little while. Or if you think, I wonder if in the future, as many of us are wondering, whether actually a lot of pediatrics will be even more in the community and less in hospital. And actually you'll see pediatric specialists as part of a GP hub. So you might do a clinic in a GP practice. It's really good, therefore, to have perhaps met some GPs and worked with a clinic with them, or try and set up a joint clinic. And there's lots of facilities within the Progress curriculum to really encourage that. There's also lots of opportunities for out of programme experiences. We do like them to be, not necessarily educational, but enriching to your life as a human. And as long as you can justify what that is, then most of them get approved. So if you say want to go abroad for a year and go and do tropical pediatric medicine in Africa, which I had a friend that did, or if you want to go and do a project that looks after children on the other side of the world, you can do that. Or if you just want to go for 6 months and work at, say, Liverpool Institute of Tropical Medicine, or if you want to go down to Gosh and do a specialist placement because they're the only place in the UK that has that super specialism that you're quite interested in, then that's really possible. So there's a lot more flexibility. There's also a lot more flexibility with time, in that it used to be quite rigid for the 8 years. Now, actually, there's a lot of points that you can shorten if you want to. So you can do, so it's they now call it core speciality and then speciality. So your ST1 to 3, which you can actually do in 2 years, your core is 2 years. That's set, as in your first 2 reg years, and then your speciality years, which you can do in 2 years instead of 3. So you can actually do the whole thing in 6. Let's be honest, don't rush. Unless you really want to. And some people have lots of good and relevant reasons for wanting to finish specialist training. But what I would say is, we all spent kind of 4 or 5 years doing adult medicine, and maybe at maximum 2 months doing pediatrics. Give yourself time. Give yourself time to embrace pediatrics and, remember that children aren't small adults. And in fact, there's lots of differences, and sometimes time is helpful for that. I really enjoyed my time as a registrar and as an SHO, and I don't think I'd try and fast forward it if I was to go back. But each to their own. Just know that there's lots of options. Going back to my list of things, punctuality is a big bugbear of mine, mainly because I'm always early, mainly because my parents taught me to be that way. But all I want in life is everyone to be to be ready for handover at handover time. And if everyone could do that, I would be at least 50% happier human. So punctuality, doesn't matter what specialty, just try really hard. If parking at your hospital, parking at my hospital is horrendous, is bad, just leave early. I eat breakfast at work because I know that parking there stresses me out. You're expected to get your MRC PCH done within years 1 to 3 of specialist training. Now that involves 2 written papers and your clinical. The 2 written papers are actually more like 3 written papers, because it used to be part 1A and B, part 2, and then the clinical. They now have, as I said, funky names, but essentially you can still do all of part 1 on one day if you want to, 1 in the morning, 1 in the afternoon, if you're suckers for exams like most of us are, and then do part 2 and then do your clinical. Life has changed a bit because of COVID, and for the last year or so, clinicals have been online, which I still, let's be honest, I'm not sure what I think about that. But my hope would be that by the time most of you come to do your clinicals, we'll be back doing them face to face, because I really think that the way you can tell someone can examine a child is to see them examine a child rather than them tell you how to examine a child, which I think is a very different thing. And finding findings for yourself is very different to being shown findings that you've asked someone to look for you. Anyway, then during, you might have decided before ST4, think about if you want to subspecialize or spin. Now, subspeciality is a little bit like subspecializing in adult medicine. If you have a burning desire to be a pediatric cardiologist, that's subspecializing. But you might not want to be a tertiary pediatric cardiologist, but you might have an interest in cardiology, and that's where spin comes in. Spin is essentially you wanting to develop a specialist interest, but not necessarily wanting to be the tertiary hospital's lead for a specialty. So, for instance, I could have done pediatric neurology, and now, to be fair, as of a couple of years ago, there is now a pediatric neurodisability subspecialty within GRID, because that's what we're talking about, essentially GRID training. But there's also spins for both of those things, and actually, letting you into a little secret, you don't actually have to do either of those if you don't want to, because if you tailor the jobs you pick, or the jobs that with you and your TPD and your educational supervisor pick towards a certain area, then as long as you have the competencies, you can still do that job. So I didn't actually do spin for neurodisability. I thought about it. Well, I actually thought about doing spin for neurology, which is why I have all my PET training, which is pediatric epilepsy training, and the CHAD, which is great, which is the children's headache course. But actually, there is a lot to be said. If you plan in your life to work in a DGH, to having a fairly generalist approach, because if I think about my own group of colleagues, my roommate, Dr. Rourke, she started off doing peds gastro when she started. She's now doing peds A&E, and peds gastro has gone to one of my colleagues that prefers to do that. And then he did that for a while. He's now doing peds asthma and allergy, because that's what he really wanted to do. So essentially, you can train up to do almost anything, number one. And also, if you have enough skills to get you a consultant job, you can then change your job plan and build that job plan into what you want it to be over time as the service allows you to. We'll come back to that a little bit more in a bit.
Question about the subspecialization. When it comes to, if you do have an idea around ST4, what you would like to subspecialize in, are there some specialties that are more competitive than others? Is it, depending on what, is it training posts that come up, or just consultant jobs?
Okay, excellent question.
Registrar jobs, etc.
Excellent question. So, subspecializing, if you really want to subspecialize, you're talking grid training. Grid training involves having a grid number. Having a grid number involves grid application. Grid application is essentially you nailing your colors to the mast and, for instance, saying, I want to be a neonatologist. And for each region of the country, there is a set number of specialist posts for grid trainees. So for each tertiary neonatal unit you may have seen or worked in, there may be 2 or 3 of those posts or those registrars that are grid registrars, and the rest that will be, generic sounds awful, but general pediatric registrars who are going through neonates as part of their core training. So what you do around ST4, if you've just, or before then, because it's never too early to start portfolioing about these things, is to start building your portfolio towards that subspecialty, to start doing more CPD towards that subspecialty, because grid training is essentially like your MTAS form and your pediatric speciality form and your then consultant application form, which essentially goes through all the major areas of life. So kind of tell us about why you want to do X, and tell us what audit projects or what research you've done into X. And then, much like everything, you get ranked, and you then get several choices, which is another interesting thing about grid. You can decide whether you will only do it in your region, or whether you would accept, so that you can do the subspecialty you want to go and do it elsewhere, as in wherever around the country has a gap, depending on where you're ranked in comparison to your peers. So for instance, metabolic medicine, pediatric metabolic medicine, there are hubs. Our nearest one for Yorkshire is Manchester. They are fantastic. They do outreach clinics in Bradford, etc. So if you want to be a grid pediatric metabolic trainee, the nearest you're going to go is Manchester, or you're going to go north or further south, Birmingham, London. So it depends how niche your area is. In terms of being competitive, yes, of course, there are some that are more competitive than others. To be fair, all grid training is moderately competitive because there's always more people than specific places. But things that are particularly competitive are neonates, mainly because lots of people want to do neonates, but it does have a grid program. So I would say for every neonatal place, there's about four or five people going for each place. What I would say is I know at least one excellent neonatal consultant who's working in a tertiary unit who did it via spin. So she wanted to do grid, didn't get grid, did get spin, didn't manage to get all her competencies through spin because of when she managed to get jobs that lined up with what she needed, went and did a fellowship-free year in Australia in neonates, came back, got a tertiary neonatal consultant job. So there is still some of, when you're working in units that you like along the way, if it's somewhere where you want to work, just be good to them as you would normally as a human, because that will come back and be helpful for you as a known entity later. Doesn't mean you'll get a job over a better candidate, but if people know you and know that they want you as part of their team, that's a good thing to have.
Okay, thank you. No, that's very interesting. And with as well, if you apply as an ST4, are you competing with ST5s and ST6s, or is it kind of you either go in at this point or you carry on with spin?
Yeah, so what it is you start grid at the end of ST5, so it's your ST6, 7, 8 years that are your grid training. But because the application starts at the beginning of the year and then there's interviews, essentially you need to think about if you want to be doing grid during ST4, because ST5 is applying for it. So as usual, there's lead time for all these things, and so that's when you need to be thinking about it.
Okay, thank you. That all makes sense. Thank you very much.
And then, much with anything, get involved. So, if you're an F1 or an F2 thinking, or a med student thinking, I really want to do peds, get involved when you're on peds, or get involved in the pediatric elements of whatever post you are doing. So we've had an absolutely fab med student recently who was on when all chaos was breaking loose on the assessment unit, and she essentially fielded all phone calls from my bleep. And just relayed messages to me, and she was fab. And that gives you some experience of kind of what it's like day to day to be doing that job. And then also, if you have the opportunity to help out with bloods or cannulas, that doesn't mean you have to do them, but actually getting that hands-on experience is going to be really valuable for when you come to do it, because instead of thinking, oh my goodness, I've never seen what it's like to try and put a cannula in an octopus, because children can be octopus, then it's much easier because you've got an idea that a nice bear hug works really well, or that Where's Wally or a tablet works really well. And then work hard. Essentially, I don't mind if you don't know everything, because I definitely don't. But I do mind if you don't put the effort in. So as long as you work hard, most of us in paediatrics will get on absolutely fine. And then please ask when you need help. I think that's true of every specialty, but most paediatricians are pretty darn friendly. You know, it's one of the great things about the specialty. We know it's different to many of the specialties because of, well, the whole extra layer of extra people involved, you know, parents as well as the children. There's all the extra issues around safeguarding and all those kind of things. So please just ask for help if you need it. So a day in the life. Now, let's be honest, this is a day in my life, rather a day in the life of a junior doing peds. But when it comes to me talking about hot weeks, they're essentially the same. So my typical day on a normal week is that I get in early. I'll check my trust email. I'll read and respond to my posts and letters. So when you're a consultant, you essentially get an in tray where every single test result you may have ever ordered comes to you. And then you have to kind of write letters out to parents to talk about results, or you need to action those things, do any mandatory training you need to do. And that comes around way faster than you would imagine, you know, kind of moving and handling, all those kind of things. Answering parental phone messages. So I remember when I first became a consultant, the whole idea that I had a secretary was a really bizarre thing. I still find it a little bit bizarre, let's be honest. But she'll send me little messages on EPR, which is our electronic system, about parents that have left messages about medicines or queries they have. And so I'll spend some time doing that. I'll check my letters, the letters I've dictated from clinic, and make sure I haven't said anything ridiculous, because let's be honest, we all do at times, and sometimes it's checking spelling and things like that. Liaise with colleagues about tricky cases, that's my favourite thing to do. I remember when I was at most of your stage, I used to think that consultants knew everything and that they were somehow magic because their brains must be insanely big. But what junior doctors don't tend to see is that actually consultants just ask each other. You just don't see it because it's not on the ward. So I really, where I work, we're all down one straight corridor. And what happens if there's a really tricky case on the ward or a really tricky case in clinic is it will essentially just come out of our rooms and stand in the corridor, because it's a closed corridor, and we'll essentially just discuss it. And then my list that was like a 5-point plan will then become a 10-point plan that is really robust because about 7 people have put into it. It's something that happens all over the country, and yeah, I think junior doctors don't realise how much it's happening, but it's wonderful. And it means that actually you're getting the very best for those patients, but you're not on your own trying to think, oh my goodness, what do I do about this patient? Because usually you won't be there having done nothing. You'll be like, oh, I've got this child with pyrexia of unknown origin. We've got urine that's normal. We've got an LP that's normal. We've got blood cultures that are normal, but they're still spiking all the time. And I'll say to my colleague, Khalil, who echoes, I'm like, can you echo just to make sure there's no vegetation? So he'll be like, yeah, of course. And then one of my other colleagues would be like, oh, have you checked EBV? And I'll be like, oh, no, I haven't. And, you know, you'll have these kind of great logical back and forth conversations. It is a brilliant thing. And actually, as you become more senior, is a great thing for you to do as a registrar or as a kind of senior SHO, because I still in my head work in old money. Then the other things I do day to day is run my clinics. So I do, when you're a junior, it's going to sound crazy saying 1.5 neurodisability clinics. But what that means in consultant time is that I do 1 neurodisability clinic every week, and then I do 1 every other week. And then I do a general clinic every week. And then all your other roles that come into, it's called supporting professional activity on your job plan. So I'm essentially one of the teaching leads for our med students. I am the designated medical officer for SEND for our CCG. So I actually go to meetings at the CCG and talk to the powers that be about funding our services and what we need in neurodisability, and try and advocate for my patients, which is great. And then I instruct on lots of resource courses, which I largely do because it's good fun. Then day in the life part 2, hot weeks and on calls. Now this is probably more akin to what you're going to be doing day to day when you're on the wards, except maybe not the latter two. So handover, I essentially let the juniors run handover, and then usually add in things like, "Ooh, did you do this?" Or "What's the answer to this?" My essential role in handover is chief questioner, because I'll have little bits of things that I want to know, because they're pertinent to my thoughts and planning on a patient that aren't necessarily part of your SBAR. Top tip for life: get SBAR down, because it's going to help you in all your specialties and in all your jobs within medicine. And when you phone a consultant at night or phone your registrar, if you can give them a quick, succinct little SBAR, so that's situation, background, assessment, and recommendation regarding your patient, oh, everyone will love you. Plus also, when you wake someone up from sleep, it's a really good way of getting them focused. And then ward rounds. So ward rounds are a big part of your life on hot weeks, and a big part of your life as a junior doctor. Now, when you are F1 and F2, you're probably not going to be running any ward rounds, but let's be honest. In the heart of winter, when it is crazy, crazy, we definitely let our F1s and F2s see our long-term patients. And by that, I mean our CF patients that are just in for like 2 weeks of antibiotics and things like that. So you might end up seeing your own ward round patients, but usually it's the art of being a really good documenter. And if you haven't come across SOAP before, which is your subjective, objective assessment and plan, that's a real good way of laying out, writing your ward round notes that my wonderful registrar taught me when I was an F1, and I've used ever since. You know, and you can add into that results and all that, and drugs and that kind of jazz, but it's a great kind of basic way of sorting out your ward round life. And then taking referrals. Where I am, we as consultants deliberately hold the referral bleep during the day, and that is for one main reason, and it is to avoid excess referrals. Because we know that we can bounce a lot more than you guys can. And that's for 2 reasons. One, because GPs don't give us as much jip as they give you. Because when you say the word, "Hello, it's Dr. Armstrong, the paediatric consultant," they suddenly don't think they're going to fight as much as they do when it's one of you guys. I know this because I've sat next to one of my juniors taking a referral, and somebody has been quite rude to them. And I've just said to them, "Give me the phone," and taken over. And suddenly people are very nice. But also it means that there's an easier streaming at the busier times of the day. But at night, the registrars hold the referral bleep. And in some places, I know the SHOs hold the referral bleeps for GPs. And it actually is a really interesting thing. It's probably a bit scary to start with, but getting a feel of where your levels should be for telling someone to come in. And also of the way you respond to challenge. You know, you'll get many opportunities in life to respond to challenge within medicine. And you learn a lot about yourself when you see how you do it. I essentially find myself being the disappointed mum figure a lot. So when I speak to A&E and they tell me that they've given nebulizers to a child under the age of 1, my colleague Kath does go, "Guys, really? Just don't do that ever again." Whereas I tend to take the more disappointed approach, like, "Oh, you do know that they don't have the receptors for those, right? Maybe next time, just don't do that." So you learn a lot about your ways of dealing with stress. Then deal with any urgent messages, which usually involves my secretary is really sweet. She essentially spends a lot of time when I'm on hot week tracking me down. I honestly think she should try using my mobile phone, which is with me all the time. But because our ward is just one big circle and I'm usually on it if I'm not in my office, she just walks around until she finds me and usually tells me of things that are urgent. And then going to recess as and when needed. Managing staffing, oh my days. This is something that nobody tells you about at medical school or any time in life until you become a consultant, which is essentially that while you're on hot week, if any person in the team is down, it is then your responsibility to somehow fix it. Now, this doesn't mean that you have to necessarily find someone to replace them, but you have to call medical staffing or your rota coordinator, whoever it is, to try and fix it. And also, you'll be the one that gets called at sometimes insane times of the day to be told that someone can't come in. I had a phone call at 5 a.m. once from a junior doctor. To be fair, they were ill. I was on call telling me that they wouldn't be in. I'm like, that's okay. You could have called at 8 a.m. to tell us this. But, you know, fair game to them. They were giving us prior warning. And, you know, it's always the joy when you're trying to manage actual patients and the load coming in, that you're also trying to manage the fact that there's no SHO or registrar on call for the evening, and what you're going to do about that. And so I'm sure all of you have had the joyous experience of a consultant asking you if you could stay on and thinking, oh gosh, they're asking again. Trust me when I say it's equally painful from the other side, because we've all been there, and also nobody wants to be asked, and we all know that it's awful and you have lives, but we also know that it is genuinely terrible to be on call with no staff. And there is occasionally a tendency to be like, well, the consultant should fix it or do it. I know this because I've done 5 registrar shifts and 2 SHO shifts in the last 6 months for gaps. So where I work, consultants more than pull their weight. What I would say is we always appreciate when you guys cover when there's gaps, especially if it's illness, because, you know, long-term gaps, I appreciate you guys shouldn't be expected to cover. That's a trust issue, not your issue. But when it's short-term, we all know it's the same people that always help cross-cover. Hopefully it's the same group of people that always do it, but anyway. And then teaching, the fun bit. Like, I always love at the end of a ward round, if we've got time and if it's not absolutely abject chaos, to have kind of 10, 15 minutes where we either talk about an interesting case on the ward or we talk about a theme, again, usually that's been present on the ward. There was one day when we had the theme of failure to thrive, because we had at least 3 babies in that were kind of jaundiced and had weight loss, and only one of them had genuine failure to thrive, as opposed to just they need a bit more milk. And so we had like a little spider diagram going on of various different causes, which was fun. So then the hard stuff. This is the bit that people don't like about pediatrics. It's, to be honest, it's not great in other specialties either, but they're some of the particular challenges that maybe put people off, which is safeguarding and breaking bad news. So day to day, there is a safeguarding clinic. This is true of most trusts I know. Ours is only on weekdays, obviously. It's in an afternoon. So essentially any calls that come in from social workers or GPs that are concerned, if someone has a bruise or something like that, they get put into the safeguarding clinic so they can have a formal medical assessment. Now, as a junior doctor, if the ward is calm enough, you are always welcome in those clinics. And there will usually always be, with us, it's usually a community registrar that's allocated to that clinic too. So there's lots and lots of opportunity for you to gain some experience in doing that. And then acute safeguarding, that's the things that rock up to the ward. And that's either things that have come through A&E, be that an injury or a concern that's come, as I said, usually directly to A&E, or if there's a child on the ward that's come in with something different and a safeguarding concern is raised from whatever corner. Now, that might be that I still remember when I was ST1, I was seeing a child that was asthmatic, fully stripped them, and they had a linear bruise on their back. And I was like, oh no. And I told my registrar, and thankfully the registrar looked after that bit of it while I just looked after the nebulizer side of things. But just have it at the back of your mind. It is challenging. We did a whole other webinar on safeguarding, so I'm not going to go into great detail now. But it is something that people find challenging. As I said, obey the universal rule of be open, be honest, and be clear, and you'll be right. And then breaking bad news. The things that people find hardest, I think, are cancer. And sadly, it's not common, which is good, but it's more common than you'd like it to be. I see at least one a month, either usually blood, usually leukemia or a solid tumour, and that's usually a Wilms or a neuroblastoma most frequently. And the worst ones are when either it's been not recognised for that for a while, or worse still, they come in just because they've suddenly had been tipped over the edge for whatever reason, and they come in and you essentially have to tell them. Again, universal rule will save you from all things. And I usually find that with challenging cases like this, words such as, well, what do you think's going on, are quite powerful, and letting them tell you, because parents are actually a lot more astute than many people give them credit for. And most of the time when they've brought their child in, even if they don't know what's bad, they'll know it's bad. A lot of the time. I can only think of a couple of occasions when I've been breaking bad news about cancer and parents haven't already known that it's pretty darn serious. And actually, by you gently leading them down that path, it's easier than going, so your child's got leukemia, which I wouldn't recommend as an opener for 10. And my other top tip, especially because I did 6 months of peds oncology, is if you are not working in a peds oncology unit, and this is going to sound crazy, be moderately vague. Now, I say this because you want to give a plan. And by that, if you know that that patient needs to start hyperhydrating with fluids, if they need to have a blood transfusion, and if you need to get them to the oncology unit, that's what to tell the parents. You don't want to be saying, oh, they have to get to the oncology unit tonight, because that doesn't always happen. You don't want to be saying they're going to have a CT tomorrow, because you can't promise that. And actually, the worst thing that you can do is work this poor family who are already really worked up more. And I think unless you have worked in a pediatric oncology unit, what you don't realize is their time span is really different to what you think it would be. So they do want to get things done quickly, but their quickly is usually within a week, not that day. Because of course, so as an acute pediatrician that's not an oncologist, I feel like a solid tumor and I'm like, hell, that needs sorting right now. And they're like, oh no, we can see that within the next 2 to 3 days. And you're like, really? You're going to let these poor parents think about this for 2 to 3 days before you do your CT and confirm and take your samples and whatever you need to do? And they're like, yeah. But they do that because then they set aside specific time to do it, and they make sure it's the consultant that can do it. So there is good reasons for it. And don't get me wrong, if someone's acutely sick, if you've got, a child with leukemia who's potentially having white cell breakdown that's causing problems, then they get them across as soon as they humanly can. But I have seen a good few families who have been told lots of detail with good intention by DGHs who the oncologists are then slightly frustrated by. And having sat in clinic with some of our fantastic oncologists, until they know the fine detail, they are very general. General is a better word than vague. You want a clear plan, but a very general plan. Then preterm babies. I think that's the other one that worries people, when you have to go and counsel about 23 weekers. And sadly, even in our days of excellent technology, and even in the days when I have an ex-23 weeker on my books, that survived, God bless him, he managed to get every single neonatal complication you can imagine, and has just started walking at about 3.5, but he's with us, and he is a joy, because he essentially, not all preterm babies look like ET, but he does, bless him. And he's a bit of a diva. So essentially, when he's when he's in a bad mood, he just covers his face with his blanket. He's one of my faves. But I can't imagine the conversation that that the registrar had with their mum, because you still have to say for 23 weekers that essentially 50% mortality, because it's, you know, you're not ready to be born yet. And there are a lot, but that conversation, unlike the conversation about cancer, is all about detail. You essentially need to prepare them for the fact that mortality is high, that ROP, so retinopathy of prematurity, is a real possibility, that sepsis and problems with feeding might happen, but that they can still express, and that that's really important. And those are all tricky conversations that my top tip would be, watch an expert do it. And by an expert, I mean a registrar that's done it a few times, one of the neonatal consultants, because the best way, much like, the best way to get good at history taking, is to see lots of different good ways of doing it, then pick your favorite bits and adapt your own style. And then sadly, there are still quite a few other breaking bad news things, because let's be honest, any chronic disease to an extent is bad news. So I would say the most common one in pediatrics is diabetes. Telling a child that they're going to have diabetes for life, and that they're going to have to think about the carbohydrates they eat and inject, is a big lifestyle change, and it's often a big lifestyle change for their family. And giving them time for that to sink in, and explain the ins and outs of that, insulin helps the powerhouse of your body to control its sugars, can be tricky. But as I said before, follow the universal rule and you'll be right for all of these things. Be open, be honest, and be clear. And then even if you don't know all the answers, you will set yourself in great stead. So we come back to picking subspecialty or spin. Really, it comes back to what you love. And I would say that for specialty picking in general, as in, whether it be pediatrics, and I'm sure I would love to see lots of you become pediatricians, but you need to ask yourself, what do you enjoy most? Do you have a burning passion for cardiology or neonates? If so, grid training might be for you. But grid training isn't for everybody. And so it might be that you want to be in a DGH, and a spin module would be more up your street. Now, spin modules are essentially getting the key skills you need for a certain bit of the subspecialty without doing formal grid training. And to do that, you need to speak to your training program director and your educational supervisor, and together they'll be able to help you down that path. There isn't spin for absolutely everything, and there are certain deaneries where doing certain spins are easier than others. So there are there are certain popular spins. So within pediatrics, diabetes and endocrinology is a popular spin. Teenage and adolescent medicine is becoming quite a popular spin. Epilepsy is a popular spin. But the way to find out more details about those is that when you start your pediatric career, discuss it with your clinical supervisor, discuss it with your educational supervisor, and then they'll be able to help you pick jobs in line with your training needs. One of the roles of a TPD, as well as to essentially put together the jigsaw that is trainees in jobs, is to try and help you to pick or to do jobs that will make sure you get the competencies you require to do a spin that you want to do. And also remember that it is okay to keep things broad and open, because this sometimes gives job opportunities. Because my other top tip is pick your place, not your specialty. Now, I know that's easier said than done. If you are a grid trainee and you've done neonates, I don't mean don't pick a neonatal unit, that's crazy. What I mean is, I largely picked where I wanted to work based on my colleagues, not on the job that came up. And actually, because I'd done general pediatrics and actually done a bit of diabetes, I'd done a bit of renal, I'd done a lot of neurology and neurodisability, I was very happy doing a job that did general and neurodis. And then you can train or do courses to boost your skills and ability in those in the areas that you are then taking on once you're there. Because it is much better to have a supportive group of colleagues that you get on with that are cohesive than have your perfect job immediately. Because the job I started doing 4 years ago is not the job I do now. Each year you have a job plan review, and so from year one I took on teaching lead, and then at year two I added on being the designated medical officer, so I dropped a clinic and I added on, speaking to lots of people at CCGs, and then year three I decided that I actually wanted a better work-life balance, and so dropped 1 day a week. But it means I can now do more resus teaching, which I love. And, I go up and down the country doing resus teaching, which is great fun. You get to meet lots of different fantastic people in different specialties as well, which is great. So, nothing is set in stone, I would say. Think about what you want from your job in the end. Then how to maximize your opportunities within pediatrics. As a disclaimer, any children in this presentation are my nieces and nephews who love being in this jazz. I know this because I gave a version of this talk to the first RCPCH F1 conference in September, and they were in the room, literally involved. Trying to get them off screen at times was tricky. So, as I've said before, what do you want from your career? Do you want to be a high-flying prof? Then get your head into research. Do you love leadership? As in, do you want to become, say, the head of WIAT, which is what one of my colleagues is? See, paediatricians, it's the place to be. So, which is the West Yorkshire network. And, he talks to head of trusts around the region about key things throughout the trust, not just within paediatrics. Do you have a burning desire to be involved in management? If so, you could think about being CD, clinical director one day. And my current clinical director is an absolute legend and balances his clinical duties with his management duties brilliantly. Do you, like me, absolutely have a burning passion for teaching? If so, there are shed loads of opportunities, be that the wonderful Mind the Bleep team, be that ALSG and the Resus Teaching Council, be that medical student teaching or peer teaching or research. I think everyone should do a bit, just because it's evidence-based medicine, it's the way forward. But not all of you have to be principal investigators on a study. You can just be someone that's really good at recruiting for studies, and speaking to families about a study that your centre is involved with and recruit. Like I used to take pride in having high recruitment numbers, even though I do not want to plan my own study. No. I'm very happy for people to put in research proposals and me to just be involved in it. I love being involved, but not necessarily the one writing hideous grant proposals. But that might be your jam. That might be where you really want to focus your energies. And let's be honest, within all branches of medicine, you need more than one hat, as my wonderful clinical supervisor started telling me around ST6-7 before I started applying for consultant jobs. essentially you need to think of yourself, what is your clinical niche? And for me, that was neurodisability. And then what is your non-clinical niche? And for me, that's teaching. And, start thinking about those things early. If you love teaching, start teaching when you're in ST1. There's nothing that should stop you doing that. I had medical student teaching groups from when I was an SHA, and then just built it up over time. And make connections. James is currently an F1 and he is doing this already. How awesome is that? Start speaking to people from around the country, doing the kind of things you want to be doing. Get involved. When you go to conferences, speak to the people that are doing what you want to do and find out how they got there, because that's the way to kind of direct your path. Utilize your unique skill set. My unique skill set is slightly interesting in that I'm quite good at drawing. The reason why the picture of my hand is on here is because me and my nieces had a day where, so my nieces really love kind of those transferable tattoos, but we ran out. And so I just started drawing extra ones with my Sharpies. and so one of the things I do, and you'll see on the next page or so, is that at Halloween, this was pre-COVID, I hasten to add, and at Children in Need, if I'm not in clinic, I'll go onto the ward for the other half of the day that's not a clinic session, and I will face paint, and it's so much fun. In fact, I took over a patient recently from one of my neonatal colleagues, because as a neurodisability consultant, you'll often inherit people. So they had them until they were about 2. They looked like they were developing cerebral palsy, and so they got passed to me. Anyway, I had this new patient on my list, didn't really recognise the name, because I don't recognise all my new patients' names, obviously. I've not met them before, in theory. And this lovely mum and this lovely little 2-year-old came through the door, and she was like, "Oh, you're the face painting one, aren't you?" Yep, they'd met me when she was on the ward with bronchiolitis, and I was face painting in the corner. So whatever makes you, utilise that. It is more of a blessing than you probably realise now, but you are who you are for a reason, and that will be ideal for an area of medicine and an area of work. And it's all about finding your niche. Take any and all good learning opportunities. I would suggest to you that all learning opportunities can be good depending on what you take from them. For instance, one of the questions I was asked at my paediatric interview to get into ST1 was, so Yorkshire has three bits of deanery: West, which is Leeds, Bradford, Halifax, which is where I am; South, which is Sheffield, Barnsley, Rotherham; and East, which is Hull. Now, funnily enough, you can perhaps estimate which areas most people want to be in, because lovingly, Yorkshire Paediatric Deanery asked the question, so if you end up in the least desirable area of the deanery, no one says Hull out loud, but we all know that's what they mean, what would you do? And so being able to think that you can always take good things from intriguing situations, and to be fair, Hull Hospital's beautiful, and actually its paediatric department is brilliant, and their resus department is the nicest one I've been to teach at. Though hilariously, as an aside, when you teach on their GIC, they have a pie day and a curry day. Never changes. There is no variation. It's just which day is pie and which day is curry. I love the North. It's brilliant. But I took one of our F1s who wanted to be a paediatric anaesthetist to theatre with me to put a long line in, because he told me that he wanted to be a paediatric anaesthetist, so I knew, and so I took him with me. Tell people what you want to do, and they will try and include you. And then work hard and have fun, because let's be honest, work is hard enough as it is. Try and enjoy the bits that you can. I was teaching on APLS the other week. No, it was when I was teaching on GIC. APLS was good fun, but GIC was even more fun. And the medical director was like, guys, there's a lot of laughter coming from your room. And I was like, yeah, we're having a great time. And that was because by the end of the day, when we'd asked the candidates if they wanted any particular style of candidate, we'd gone through kind of nervous and overly confident. My co-instructor was a fantastic anaesthetist from Wales called Steve. And one of our candidates had decided they wanted to see Party Steve, except it wasn't Steve's turn to be the candidate, it was mine. So I had to be Party Steve and put on my most terrible and amazing Welsh accent while doing an NLS scenario. It resulted in everyone nearly crying with laughter. And all I could see in the background is poor Steve trying to mark while his shoulders going up and down. It was great fun. Medicine's great, guys. You've picked an excellent career. There's bad days, but there's many more good. And then a career in paediatrics can open all kinds of doors for you. So let it. If you want to do something, go out and grab it. So I teach on NLS, APLS, and GIC. Again, pre-COVID, but I think shortly again, when things improve, GIC and NLS have been taught in Cameroon and Africa, and various members of my clinical team go out and teach it. Doing medicine abroad or placements abroad, giving back to your local community and fundraising. So CHFT is Muddy Medics, so we've ran Tough Mudder 3 times. We're due to do it again in 2022. We've raised money for our children's ward. We raised money for one of the local projects, and it's great fun. Highly recommend it. You don't all have to do 10 miles and 30 obstacles. Whatever you find more satisfying. You can sit in a bath of beans if you want, whatever you like. But do challenges in team building. My favorite thing to do at the end of my hot weeks, again, this was pre-COVID, on my Friday morning handover, we do a quick game. And there was one week we did fluffy bunnies, best thing I've ever seen, which was the standoff between our paediatric ST1 and one of our GP ST1s as the last man standing in fluffy bunnies. They each had about 14 marshmallows in their mouth. It was chaos. There's a brilliant video on Facebook. I will send you the link if you really want it. It makes me cry with laughter every time. I do send. I've also recently, so I'm going to be the medic. My terrifying title is crew leader. The medic / crew leader for 2 of the Ellen MacArthur sailing trips next year. So we take away kids who've survived cancer and essentially remind them that life is still, you can still live life even as a kind of person that's in remission. And you essentially have campfires and sail, and thankfully there's a genuine captain who knows how to sail a ship, because I may have posted as my Facebook status, watch out, poor cancer survivors, we might sink. If they were tasking me with sailing the boat as well as looking after their medications, which I am more than capable of doing. And then, as I said, be yourself. You can only be you, and I would encourage you to be nothing less, but nothing more. Bring the things that you find joy out of, your dreams of what you want to achieve, to your work, because it's going to drive you to make change. Change is not always easy, but is really important. If you think, oh my goodness, there are too many children in the UK that are obese, and we know that that is a national problem, well, then think what you can do to make it different. Or so recently, I am sad in a clinic that respite services for children with neurodisability have been eaten away by various different things. So volunteer organisations haven't been able to sustain things through the pandemic and things like that. And so me and a group of my colleagues are trying to set up a little charity where we take kids out for days out. And I do that based on the skills that I learned through doing everything else leading up to now. So be you. It's going to be your biggest asset. And then paediatrics genuinely is great. So these pictures are, this was the first time I saw my nieces and nephews. after the first lockdown, and essentially all three of them wanted to sit on my knee at the same time on a beach. My sister was like, you work in a hospital, I will only meet you outside, which is fine. So we were on the beach. Then the middle picture is one of my beautiful patients with epidermolysis bullosa. So it was a face painting day and we couldn't paint his face because his skin's too delicate. So I had hairsprays and his mum was like, yeah, absolutely. And so we rainbow sprayed his hair. Brilliant. And then this was Halloween when I essentially went around painting. These are just the doctors. And we painted the other doctors. Peds is one of the only truly generally specialities left. You can essentially do any area of medicine within pediatrics or all of medicine within pediatrics if you want to be a general pediatrician. As I said, you can make your final job what you want it to be over time. And work genuinely can be fun. I would say more of my days that I go into work I enjoy than I don't enjoy. There are always going to be elements that you don't enjoy, but thankfully they are less than the things you do, I would hope. Do the essentials. You still need to do audit, you still need to do governance, quality improvement and research, but do the fun stuff too. For me, that's fundraising and face painting. And, you know, we have a yearly outing to Alton Towers. To be fair, that is just the consultants. So some of our group go to Alton Towers every year. It's great fun. We cause jealousy within the ranks of the neonatal team who haven't yet got themselves together to do that. But in the summer, we'll find an evening where as many of us as possible can go, and we'll go to the local pub for a couple of drinks with all the consultant team, and it's just really lovely. I would encourage you to find a group of colleagues that you get on with, where you all look after each other. It is the best thing I have found. So that is enough of me rabbiting on. Is there any questions?
Okay, so I'm just having a quick look at the chat, see if anything's popping up. So if you do have any questions, please do stick them in there now. But thank you very much. I found that really useful, really interesting. And also just, I mean, I've seen it from careers talks and things before. It's just so nice how pediatrics very much considers you as a person and a whole person that isn't trying to just tick box or cram you into their box. And actually it kind of, you know, and I think it's the way to get the most out of people. But like you say, you can do the things you enjoy and the things that you want to do and find a way to make that into kind of your day-to-day, and that's really nice. But okay, at the moment I can't see any questions coming through, but if anyone does have anything, do stick it in the feedback, or you can always post it onto the Mind the Loop Facebook page and we'll try and get an answer back to you. Okay, so thank you very much for this evening, Dr. Armstrong.
My pleasure. So we always at Mind the Bleep really appreciate your feedback, good, bad, constructive. Please, I would like to think that any bad is always constructive. So please do take some time to fill out feedback for us, because I really do take notice of it. And also, portfolios, I'm afraid, guys, never cease. They just change how they look over time, and this genuinely goes on my portfolio.
Yeah, and we've had really, really good feedback so far, actually. Really useful stuff, specific, detailed, and like Dr. Armstrong said, we really do appreciate it. So I've posted the link in the chat on the video. The feedback form is normally live for about a week after the event. So if you are watching this several days after the event, whether on Catch Up on Medal or on YouTube, you can still go fill out this feedback and you'll get a certificate for your portfolio as well to say you attended the event and have shown an interest in a career in pediatrics. Okay, and I will just finish the stream there.